If you need to go, go. Yeah, that's totally fine. I'll give people a few more minutes to fill in.
Find it back there.
Right. We are tucked back.
Yes, you can move. Not yet because there's not many people, so I take this seat.
I do. I work over at Children's, yes, and I'm not a physical therapist. I'm a doctor. I'm a pediatrician who then was double trained in peds and PM&R. So, yeah. So thank you. Yes. But I work very closely with our physical therapists.
Yeah.
Awesome. Should I get started? What do you guys think? I can give a few more minutes. Everybody ready? We can go ahead and get started. So I'm Dr. Ann Stratton. I'm one of the rehabilitation physicians over at Children's Hospital right across the street and in the Rett and Rett-like conditions clinic here at Children's with Dr. Benke. And so today I was asked to talk about rehabilitation and CDKL5. And so this is going to be a pretty broad topic. Hopefully we'll learn something together. All right. So I have no financial or personal interests to disclose. I'll let people get settled. All right, and if in the back you need to move around or come or go or whatever you need to do, that's fine. So like I said, I'm Dr. Ann Stratton. I'm one of the rehab doctors over at Children's Hospital right across the street, and I'm in the Rett and Rett-like disorders clinic with Dr. Benke. And we're going to talk about rehabilitation today. So I have no financial or personal interests to disclose. And the objectives of this talk are to discuss the role of therapy in CDKL5, including some setting therapy goals, monitoring, reevaluating, and assisting with equipment and bracing. We're going to discuss the different disease-associated conditions to consider when you're planning a rehabilitation program. And then discuss the different therapy modalities that are out there. And hopefully give you a somewhat broad overview. Of course, I want to leave plenty of time at the end for questions. So we'll jump right in. I think this is probably the most important piece of setting up a therapy program is really set up good expectations with your therapy team. And first and foremost, as you all know, CDKL5 is rare. And people haven't heard of it more often than not. And so when you're going into a therapeutic relationship, discuss with your therapist, do they know what CDKL5 is? Would they like a little mini tutorial before you get started, before you establish that therapeutic relationship? It's also good to discuss with your therapist what to do if there's a setback, or if your child plateaus for whatever reason. As we all know, this is a complicated disease, and there are going to be setbacks, and there are going to be times where you aren't going to have rapid gains in progress. And is that clinic setting one that is okay to roll with that? Or will they say, you know what, we need to take a break from therapy? And so setting up those expectations in advance can be very, very helpful. It's good to discuss, is your team able to get creative within the limitations of their clinic setting? Some clinics have a lot of flexibility in the team that they put together, and others are fairly limited in their ability to get creative, maybe due to insurance restrictions or just how the clinic is set up. And so you want to know that in advance and discuss that with them. And then also really consider with your therapist and in setting up those expectations, what schedule works best for you and your child. Does your child a morning person? And so it's good to get therapies done in the morning, because then in the afternoon they just have less energy or tend to get fussier. Or is your child really not quick to get going in the morning, and an afternoon time works better? And talk about that with your therapy team. So setting up therapy goals is another important piece. There are several different types of goals to think about when you're setting up the goals for your children. They're developmental goals. Those are the goals such as that everyone thinks of: standing, walking, mobility, reaching, feeding, and communication. Those are your big developmental goals. But that's not necessarily attainable for every child at all times. You can't always push forward on those big developmental goals. Sometimes you're looking at smaller functional goals. So you just want your child to be able to assist with dressing a little better, be able to bridge perhaps, or reach out to get their arm through a sleeve. You wanted them to assist with weight bearing, to help with transfers, and to help get them dressed. Those are very important functional goals. And then communicating needs and wants. They aren't necessarily big developmental goals, but these are very important pieces. And then there's simply ease of caregiving. And that can be improving range of motion in your hips so that you can make it easier to diaper, improving positioning to decrease effects on skin, and then help with other positioning options to help with respiratory drainage and to help with constipation. And you need a team sometimes to help with those small goals. And so frequently, when you're talking with your therapy team, you may have some goals from each one of those categories. And it's important to really set those goals, and your therapist will appreciate you thinking about them in advance. As you are going through this process, it is important to constantly reevaluate. And hopefully your therapist will be on board with that and reevaluate with you also. And maybe your child has met a goal. That's fantastic. Does that mean they need to be discharged from therapy? Probably not. I'm sure that there are new goals to be set. If you have a medical setback, you need to reevaluate and potentially hold on the goal that you had been working towards. And if it's a significant enough setback, your goal might simply be, let's get back to our previous level of functioning. After a long hospitalization, that's a very reasonable goal, and you want to talk about that with your team after a surgery or something like that. Or perhaps you've got some teenage attitude or three-nager attitude, and you need to mix things up a little bit, and you need to talk with your therapist. How can we adjust for this and get my child to re-engage in therapy? Another piece that your therapist should be working with you on is equipment and bracing. So these are tools for your toolbox. There are no hard and fast rules about wearing bracing. It is a tool to work on positioning. It is a tool to work on support for your child when they're doing certain activities. It is a tool to help you with stretching and decreasing contracture. And then equipment also can have goals of a stander, can have a goal of helping your child open up their stance and work on head and trunk control. It can help with digestion, actually, and sort of helping things move through a little better when you're up in a stander. And so I want you to think in terms of equipment pieces that you're discussing with your therapist, that these should have goals also. There are millions of different pieces of equipment out there, and you could fill your entire house plus your neighbors with them if you wanted. And so being very thoughtful and deliberate about what equipment you bring into your house for your child can be helpful for you. And of course, these will all change as your child grows and develops, and you will need to reevaluate what equipment and bracing that you're using. So, CDKL5 is rare and unique. So what should my therapy team know about it? What do I need to think of in regards to making sure that my therapy team is a right fit for my kid? So we're going to touch on cortical visual impairment. We're going to touch on sensory processing issues, movement disorders, scoliosis, and seizures. So first off, cortical visual impairment. So visual processing, and I do hope that that you see Christopher Russell's talk tomorrow at 8:15. I've heard it's wonderful. But visual processing impacts movement and mobility. It can impact how your child learns, how they interact with the environment. It can impact communication. You have to change potentially strategies for communication based on your child's cortical visual impairment. And visual processing, as you all know, can change your depending on how your child is doing at that time of day. They may be having a great vision day, or they may be having a rough day where their vision just isn't kicking in as well. And so it's very important to talk about this and make sure that your therapy team understands this so that they can help troubleshoot and problem solve around this issue also. I have found that it's really, really helpful to utilize the blind and low vision resources in our area. We have in Denver are very lucky to have the Anchor Center locally, and they've got wonderful, wonderful resources for our families and are used to working with kids that have low vision and cortical visual impairment. And so they will frequently consult with some of our local therapists to help troubleshoot around ideas. So I encourage you to reach out to organizations in your area and see how they can add in a piece. Sensory processing issues. So this is another big piece that can be hard to explain to therapists sometimes. These, our kiddos have processing delays. You cannot give them a command and expect them to immediately respond. You have to be patient and give them time. They have impaired proprioception. Understanding where their body in space is lying in space can be difficult for them. And then they also can have pain insensitivity. And so those are three important pieces to consider when you are working in a therapy setting. So discuss with your therapist that we need to be patient and give a certain amount of time to expect a response. Deep pressure input can be really, really helpful in a child that has trouble with proprioception, trouble with understanding where their body is. And so we use different tricks. We use compression garments sometimes. We use weighted objects and weighted blankets to increase proprioception. And so those are things that you can throw out with your therapists. And then also the decreased pain sensitivity can be a very important piece. I have had patients have fractures and the family not realize it immediately because of that decreased pain sensitivity. A slight reluctance to weight bear might mean that actually there's a femur fracture. And so being on the alert for that and having your therapy team be on alert for that is important. As we know, one piece of this is that our kids have a little decreased bone density, and so maybe higher likelihood of having a pathologic fracture. And so that's something, if you see some swelling and redness and a little bit of grimacing, but no overt crying, don't blow it off. Have them checked and make sure that there isn't a fracture. So movement disorders is next. And Dr. Sutter, I believe, is giving a talk tomorrow on that. But there are CDKL5 patients have quite a mixture of movement disorder types. There's a lot of hypotonia, so they have a lot of very loosey-goosey ligaments and an excessive movement. And then they have dystonic posturing, which is sort of that writhing, twisting movement and positioning of their feet and of their hands sometimes. And then they also can develop some spasticity. And so those are all things to consider. It's important to understand that fluctuations in these movements can occur depending on how they're feeling. If they're ill, or they may be more hypotonic than normal. If they're constipated, they may be more spastic or dystonic than normal, or exhibiting, or if they're having pain, that can increase your spasticity. And so it's important to talk about those things with your therapy team as well, and make sure that they also understand that these are some of the ways that your child can change and have a good day or a bad day. It's important to discuss medication options. As a rehab doctor, I prescribe a lot of medications. I didn't include that in this talk, but I will use strategies such as focal tone management with things like Botox at times, or sometimes I'll use systemic tone management with medications like baclofen or Valium to help control these movement disorders. But your therapy team should be on board with these things. I don't want to make these decisions unilaterally and then have your therapist go, well, they're a limp noodle. What's wrong with them? No, oh yeah, we just started baclofen. So they need to be on board with these decisions that we make, and so that your doctors and your therapists are communicating and making sure that your child's functional outcome and best interest is at the core of what we do. Your therapist also can use bracing and positioning to help manage some of these movements. So spasticity can actually be managed fairly effectively with certain types of bracing. Now, sometimes dystonic positioning or worsened spasticity can actually cause skin breakdown inside a brace. And so it's a balance, and we always want to look at that. But sometimes you can get away with bracing and hold off on medications. And so those are important considerations. But you do want to always monitor skin closely because, again, as our kids, they can't tell you that, ouch, this is hurting, I'm getting a blister. Scoliosis, unfortunately, is very, very, very common, and it typically worsens around adolescence and makes positioning harder. So this is something that you and your therapy team will need to evaluate for and monitor for pretty routinely. If around age 12, suddenly your child isn't sitting as nicely or seems to be more off balance, I would recommend going and having them checked for scoliosis. We typically get a baseline scoliosis x-ray between age 6 and 7 in our clinic, and then we monitor clinically at clinic visits, and then we monitor with x-rays on about a yearly basis. Around the time of adolescence, though, we can escalate that depending on what we're seeing clinically and how quickly the child is growing, and sometimes we'll go up to every 6 months with x-rays. At a lot of pediatric centers, they have very low dose radiation x-rays available now, and so I would ask about that option because I know it's a lot of x-rays. As if your child does develop scoliosis, we always get questions about bracing, and unfortunately the literature has borne out thus far that it may be able to postpone the need for surgery a little bit, but it does not eliminate the need for surgery. You never, unfortunately, get out of surgery because you've done bracing. But that may be helpful if your child is having a particularly rough time clinically with respiratory status or seizure status, and you do not feel comfortable with them going through a big scoliosis surgery. Brace for the meantime and see if you can get through that rough part medically and then move on to surgery. Or perhaps your child is particularly healthy at that period of time and the scoliosis is progressing quickly, then you might not want to postpone surgery and take advantage of your child's healthy clinical window and do surgery and then be done. So there are different types of scoliosis surgery available now. There is the traditional fixation where as soon as the rods are in, it's one and done, but your child's torso does not grow any longer. Most kids actually stop growing in their torso, but around age 10 or so, so we like to postpone surgery, if possible, until then. But now for severe cases of scoliosis, there are growing rods, and there are traditional growing rods that require a surgical expansion every 6 months or so. And then there's a new technology called magic rods, which use a magnet. They're rather remarkable. They use a magnet to expand, and so there's no repeat surgery for those. So discuss those options with your surgery team. We have at Children's a high-risk spine team that really works with our patients and all of our CDKL5 patients that have undergone scoliosis surgery have gone through that high-risk spine team. And on our high-risk team involves a pulmonologist, an anesthesiologist, a cardiologist, and then of course our spine surgeon. And so that everyone talks together about how to make the inpatient stay and the surgery go as smoothly as possible, given that our kids are fragile. If your child does need scoliosis surgery, I strongly recommend talking about this with your therapist and having a plan to intensify therapies after surgery to get them back to their prior level of functioning. Seizures. Obviously, this is a big one for our population of kiddos. And it's really important that you talk to your therapist about your child's personal seizure type. So they need to know if this is a partial seizure that you just wait it out and things are going to be okay, or if this is a generalized tonic-clonic seizure that could result in injury if they're in a certain position in the gym or in the water, or if your child has drop seizures and potentially could injure themselves. So your therapist needs to be prepared and aware of your child's seizure type. And I recommend having a seizure action plan with your therapists so that they have thought through the scenarios with you and can move more quickly and more effectively should your child have a seizure in therapy. You may need to be flexible and have your therapist understand about the flexibility and have maybe a backup plan. If your child has seized all morning and is really not doing well for their afternoon therapy session, talk with your therapist in advance. Is there a lot of flexibility, and is it easy to reschedule a therapy session on another day at another time when they're doing well? Or are they pretty rigid and you need to fit that therapy session in, but maybe not work with your child as much and maybe just do some education or something else. But talk with your therapist and have a plan so that neither of you are taken by surprise and frustrated by that event, because seizures happen. So now I'm going to move on and talk more about therapy modalities, and we're going to start with core therapies. So traditional therapies can occur in the clinic setting, at home, in the school setting, or a mixture of all of these. Typically, traditional therapies are administered 1 to 3 hours per week and include physical therapy, occupational therapy, and speech therapy. Physical therapy works on gross motor movements, so big muscles, big movements, mobility, standing, positioning. They also do a lot of equipment training. They will work with you on positioning in the stander, positioning and working on gait, perhaps in a gait trainer or a walker, working on wheelchair fitting and propelling if your child can do that, if that's a goal. They also work on bracing recommendations and can train you when an appropriate time is to use a brace and what you want to use that brace for. They also work on joint range of motion and can establish home exercise programs with you. Occupational therapy works on skills for daily life, school, and tend to be fine motor tasks, but not always. They also can work on hand and arm use, function, strengthening, splints, and bracing. Should you be developing some contractures in the hands, they can customize splints for that. They also work with your child on adaptive tools. Some environmental access also can be facilitated through occupational therapy. Frequently, feeding therapy is also done in the realm of OT. They work on chewing and swallowing assessments. And a lot of some OTs may have gone on and gotten additional training in children with visual impairment. So an OT may be a really nice resource for you to work on that visual impairment piece. Speech therapists work on mouth movements. They work on forming sounds and chewing and swallowing as well. They work on speech production, speech comprehension, and also supplemental ways to help facilitate communication. And frequently, they also will help assess cognition. And so a speech therapist is a crucial piece to have, especially when working with the school system. And so I encourage you to seek that out. I have unfortunately had patients come to me saying that they were told that their child didn't qualify for speech since they weren't going to talk. And that's terrible because a speech therapist does so much more. And that, the finding other ways to communicate is an important aspect. So, additional therapies that you may be interested in. So these therapies may supplement your core therapies, but also we all only have 24 hours in a day. And so there may be times where you want to upregulate focus on one piece, and you may decide to replace a core therapy, at least temporarily, with something else. And so some of the things that you might consider would be vision therapy, augmented communication-based speech therapy, so that's a subspecialty of speech therapy, or ABA therapy, which is applied behavioral analysis therapy. And I'll go into a little more detail. So vision therapy, some vision therapists have an occupational therapy background, and some vision therapists have an optometrist's background. And it's up to you and your child's needs and who is in your area to determine who might be a better fit for you. If your child is already getting OT and you want to keep your OT, it might be good to seek a vision therapist that actually has an optometrist background that can complement them. So that's an important distinction to understand. The vision therapist should have a certified vision rehabilitation therapist designation. So there actually is a certification that they undergo. And again, if you're having trouble finding a vision therapist, it can be really helpful to use local resources for the low vision and blind. There also is another component to consider, and this is not a vision therapist, but there are visually impaired teachers that also go through certification. And those are teachers that work with the school system that are specifically instructed in how to work with kids that don't have normal vision. And so they can be a very good liaison for you. to help decrease your frustration, your child's frustration, and the school system's frustration. Augmentative communication-based speech therapy is, again, like I said, a subspecialty within speech therapy. And so they do everything from low-tech to high-tech. And really, their job is to not only train your children in how to use these devices, but how to train you, and how to train your therapists, and how to train your teachers that are all interacting with your child. Because if you've got a fancy computer and nobody knows how to turn it on or get it to go to the next page, it's not going to be used. So an example of a low-tech option is something called PECS, and that's a picture exchange communication system. It is, probably some of you have heard about this, and basically uses picture cards that your child either hands or indicates, looks at, or taps to indicate their needs and wants. It does require training. There's a specific system for it. If you use the official PECS system, it's actually trademarked. And then there are the very high-tech devices, the computer-based communication, and those can produce speech for your child. So your child can either tap the screen and then it will say the word out loud for your child, or there are even eye gaze devices that even can be used in children with CVI. They can be programmed with high contrast and a certain placement. So there's a lot of adaptability within these devices, but obviously that increases how complicated they are, and I really recommend working with an augmentative communication trained therapist, speech therapist for these. ABA is applied behavioral analysis therapy. It is very, very popular in the autism world. But I have had a lot of patients actually through our rec clinic that have undergone ABA therapy and have found it very, very helpful. So it is usually run, the ABA therapy is usually run by either a licensed clinical psychologist with training in behavioral interventions or a behavioral analyst that has gone through credentialing. And then they supervise either paraprofessionals or other therapists to administer the therapy, and it's very, very hands-on. Things that you should look for in an ABA program are the use of discrete trial training, and possibly natural environment training. There's a lot of literature out there that you can read as far as the differences and the pros and cons of the different components of this. Also, errorless teaching is another strategy that is used. But these are all strategies used within ABA therapy that can be really helpful in working with your child. So now we move on to different therapy modalities where you augment the environment that the therapy is provided in. So specifically, I'm going to talk about hippotherapy, aquatic therapy, and music therapy. So hippotherapy is PT, OT, or speech therapy. It can be any of those modalities delivered on the back of a horse or with a horse. Therapeutic riding is something else that you may find out there. There are therapeutic riding centers, and that can have a lot of benefit also, but is not necessarily supervised by a therapist. There are times where you may want to keep your core therapist, your PT, OT, and speech, but add in some therapeutic riding. And in that case, you want to, you don't want to use up your PT, OT, and speech times with horseback therapy. You want it as an addition. And so then it would be great to work with a therapeutic riding center. There are other times where your child needs a break from their traditional PT, OT, or speech, and you say, but I still want them to get this work, but let's do it in a different environment that might be more stimulating. Let's do it on horseback. And so then you would actually exchange out the therapy, and it would be provided on horseback. It can be hard to find places that do this. If you have PTOT speech delivered horseback, you can sometimes get insurance to cover it. Not commonly, but you have at least a chance in some cases. Therapeutic riding is never covered by insurance that I have found, but there are some waiver programs or supplemental programs or resources that you can apply for through your community perhaps that might provide money to pay for this. It is expensive. It is, but it's pretty cool, actually. I find that the things that you can do on horseback, it's very engaging for the children. It provides a lot of sensory input, which we're seeking. They get the warmth of the horse, they get pressure, they get the texture of the horse's fur. They really have to adjust their movements to compensate for what the horse is doing. So it works on that core strength. It works on their balance. Straddling a saddle is a great stretch for the hips, and it's fun. So I have had kids just really open up and engage when they are on horseback in ways that they don't necessarily do in clinic. Aquatic therapy is another modality that is typically physical therapy, but could also be occupational therapy. And I suppose if you found a speech therapist willing to do speech in the pool, why not? Again, you have that balance between, are you going to replace your core therapy and do it in the pool, or are you going to do something like therapeutic or adaptive swimming, where you would be with an instructor familiar with special needs patients? Again, pros and cons to both, and you need to decide what's best for you and your family. Water is great for a weightless environment that your child can move in, and so strengthen them in ways that they might not otherwise be able to do. It really can be helpful. You eliminate gravity, and suddenly they can have greater range of motion than they could before. It's great sensory input also. A warm water pool can be very relaxing and help control tone and spasticity, again, helping them to move, and it's fun. Lastly, music therapy is another wonderful option. I have really enjoyed seeing kids respond to music. Not only is it fun and stimulating, but the vibrations that music can produce. You have a child's hand on a drum and they feel that vibration. That can be a big sensory input. It facilitates movement. They want to reach out and hit the chimes or hit the drum, and it really encourages that vocalization. A child that is shy and withdrawn can suddenly just be an opera singer in a music therapy classroom. Again, and it's also fun. Frequently, these are in group settings, and so you get some socialization to this, and it can be great. So a certified music therapist is who you're looking for, but there are also some occupational therapists and speech therapists that will also do their therapies in the setting of music, and so those are things to think about. So now I want to move on to therapy delivery options and some other therapies. So we're going to talk about therapy intensives, therapy camps, and therapy-based schools. So therapy intensives are intense. It is 1 to 3 hours a day, 2 to 5 times a week, for 3 to 4 weeks, 2 to 4 times a year. There's a lot of variability in that, I understand. But it really depends on the programs that you're looking at. Typically, it is a single therapy, so it would be a PT intensive, focused on one goal. And so you may do a therapy intensive and just hammer standing to help with transfers, but your child is getting lots of repetition, lots of input, and really reinforcing that behavior. There are some cases where the intensive is delivered using a method, and such as a special suit. There's a picture that I have up here that is a TheraSuit. There's other names for similar type suits, a deli suit and penguin suit, and over in the UK I think they're called spider suits. But anyway, so this is one modality that you may hear of that's out there. The thing to know is, at least in the US, this is considered experimental and investigative and is not paid for by insurance. And unfortunately, there are no good studies that show that it is, that this delivery method is necessarily more effective than a traditional intensive. So that's something to consider. And so they are expensive, but it's pretty cool. So the Adeli suit and the TheraSuit, the theory is that you have rubber bands and harnesses and the like that help pull your child into better positioning. And then they have resistance bands against poorer patterns of movement and other things that facilitate better patterns of movement. And so that's the idea behind it. It was actually developed originally for the Russian astronauts, the cosmonauts, to counteract the effects of weightlessness. And then this was adapted for children with cerebral palsy, and has taken a lot of popularity. But again, it is intensive, it is expensive, and it may not be the right option for everyone. A good physical therapy intensive may be just as effective if you're able to work that out with your own physical therapist. So therapy camps are an option for you. And these are usually more multidisciplinary. So a therapy intensive is usually one therapist or one type of therapy, so PT, OT, or speech. A therapy camp is usually more multidisciplinary. Again, goal-directed. You want to set up goals with your therapist in camp, and usually it's 1 to 2 weeks with 3 hours of therapy a day. And it can be a mixture of group and individual therapy, and these are so fun. Lots of social and emotional benefits for these kids. And they usually will involve some adaptive recreation options. A lot of camps, I don't know if you've heard of Adams Camp. We have an Adams Camp here in Colorado. I know that there's one in Texas, and there's some scattered throughout the country. But Adams Camp is an example of this type of camp, and they offer family involvement options too. So you can actually come and do summer camp with your kids. They go off to therapy, and you do other things, and then you come back together. But I've had families that have really positive experiences from this. Siblings are welcome also in some camps. The next option to consider is a therapy-based school. So a special needs focused school. These are not widely available, and they are frequently privately owned and require tuition, so they can be quite costly. But they are multidisciplinary, so there are multiple therapies provided, and it is 5 days a week and potentially year-round. And they're pretty they can be pretty amazing. They do have a spectrum of special needs children usually in them, but there is little to no mainstream integration. So that is something to think about. If that's important to you, then that would not be necessarily available in these schools typically. So, putting all of this together, because this is a lot. I highly recommend the most important thing is to set specific goals with your therapy team, and then constantly reassess them so that you and your therapist feel good about where your child is and where your child is moving, and feel like you're not spending your 18 hours of your day going to therapies for no good purpose. You want to consider, as you're making your therapy plan, your child's needs. Some children may be doing quite well motorically, but need more concentration on speech. Some children may be excellent communicators, but need more help with their gross motor and fine motor skills. So you also want to take your family's priorities and values into consideration, and the time cost to your family. We are all limited by 24 hours in a day, and most of us have more people in our lives to consider than just ourselves and our affected child. And then, of course, the financial cost to your family. So these are all things to consider, and I will never fault you, and no one should ever fault you for making those judgments and saying, look, it's okay, we're going to focus on one thing at a time for right now. And then always be willing to change course if something doesn't work. Don't feel like you've got to hammer away at something if it's not working. Give yourself the permission to change course. That's my advice. So I don't want any of my families to ever feel guilty about feeling like they didn't do enough or they did the wrong thing. So, all right. Any questions? Yes. The
therapies in the school setting.
Uh-huh.
They seem to be working off a slightly different model. It's the educational model versus the medical model. Can you maybe explain a little bit about that and if there's overlaps or where we should try to balance those things?
Absolutely. That is a very important distinction. So the question was, can I talk a little bit about the distinction between school-based therapies and either home or clinic-based therapies, which is an excellent distinction. So in the school system, they are required to provide therapies that achieve educational goals. And so they are pretty focused on just the educational goals, and getting your school therapists to incorporate other goals in can be difficult. And so things that I find are very good in schools or tend to be very good in schools are speech therapy, because speech, communication, learning, those are all more obvious educational goals. However, there are a lot of school systems that do not have an augmentative communication specialist, which is sad and difficult for me to wrap my head around sometimes, but I'm sure it's just a funding issue or a resource issue. And so you may need to augment your school speech therapist, who may be wonderful, with an augmentative communication specialist. Occupational therapy, you may have a great school occupational therapist that works on your child's handwriting or being able to sit still in their chair or other school-based goals, but may not work on their positioning and splinting of their hands or other options. And so you want to be aware of those limitations that your school therapist might have. So, any other questions? Yeah?
Are you familiar with the method?
The Annette Banal method. I'm not as familiar with it. Mike, do you mind helping me out?
First off,
Yeah.
thank you for an amazingly insightful and comprehensive talk about therapies.
Thanks. I'm pulling in my former physical therapist in clinic who just happened to show up for my talk, and I'm delighted. So this is Mike Benet. So, yeah.
So Annette Banal was formerly trained by Dr. Moshe Feldenkrais, who was fundamental in the development of a lot of the approach on which we approach, thank you very much, how to emotionally approach movement and to kind of integrate a desire to produce movement. There is no specific published research in support of the ABM method. Now, there's a lack of research in a lot of different techniques, and so that's not necessarily to denigrate that approach, but I would encourage that there is some good research with regard to what should happen in a therapy program, and usually that strengthening is the number one impairment-based component that can produce functional gains, and so strengthening is always a good thing. And a lot of the things that you showed there, like the Adeli suit and the therapy, TheraSuit, are effective and really are focusing on strengthening. And then the other component that is really important for therapies is focus on function. You can take all the different therapy methods like NDT and a lot of different things like that, and if you don't actually practice that functional end goal, you won't have good results. If you use a lot of these different techniques and then make sure to integrate that functional end goal every session, that's when we start to see good results.
He's so smart. All right, any other questions? All right, thank you.